Well, hello, and welcome to this month's podcast, where we'll bring you up to date with the latest information and data in the world of rheumatoid arthritis. Well, joining me today is a fellow member of the IMED Forum Steering Committee, and I'm very proud to say a very good personal friend, Len Calabrese, who's Professor of Medicine at Cleveland Clinic, Lerner College of Medicine in the United States. Well, welcome to the show, Len. Great to have you with us.
Thanks, Ian. Happy to be here.
I'm delighted. I always learn when I talk to you, Len, so I'm looking forward to what happens today. And today, for that matter, we're going to be reviewing papers by Sue and Candile in which we compare the efficacy and safety of JAK inhibitors and TNF inhibitors for rheumatoid arthritis, while also uncovering the best treatment strategies for difficult to treat rheumatoid arthritis. We're going to be thinking a little bit about the importance of personalized approaches in managing this complex condition. So, the other thing, of course, to remember is that if you want to see the summary slides, the papers we're discussing today, please visit imedforum.com. That's imedforum, all one word.com. And you'll see our critique, the strengths, the weaknesses, the limitations, and the lessons that we should be learning from this literature. So I'm going to just turn to the first paper. Len, I'm going to hand over to you and hear what you've got to say. Thanks.
Okay. So this first paper by Sue and colleagues, this is from a academic center in mainland China. And it's entitled Efficacy and Safety of Current Therapies for Difficult to Treat RA, Systematic Review and Network Meta-Analysis. So, the background of this, difficult to treat RA is, I think, one of the greatest volumetric unmet needs in rheumatology. RA patients who can't have their disease controlled despite the use of, two or more conventional synthetic DMARDs, biologic DMARDs, or targeted synthetic DMARDs. That kind of forms the definition of what D2T RA actually is. We're all kind of familiar with the data that, the majority, 2/3 or so, of D2T RA patients have failed to achieve disease control, and nearly half have experienced a second treatment failure, either due to drug resistance or adverse drug reactions. So this paper uses a network meta-analysis, and this is pretty fancy statistical stuff, and I've got some questions about it in the end that maybe we can discuss. But the effort is noble, and they're really trying to define what optimal treatment of D2T RA is, based on both efficacy and safety gleaned from the extant literature that have done comparative analysis of a number of drugs. So they had 42 studies that they included in this investigation. And, the metrics are well known to us. DAS28, when they looked at that, the JAK inhibitors did very well. Bera and Tosi improved with increasing dose. Baricitinib, I should note, this is at 4 milligrams a day. So that's really important for us over in the United States, where we don't have great dosing flexibility. And tocilizumab, 8 milligrams, were generally considered more effective. DAS28 improved different drug scores. The top three that seemed to affect efficacy were tocilizumab at 8 milligrams every 4 weeks, Bera 4 milligrams a day, and Opinnercept, a biosimilar, at 25 milligrams every 4 weeks. So tocilizumab improved DAS28 the best, and Opinnercept performed the worst. These are just data that came out of this, fancy statistical analysis. When they looked at ACR 50 to evaluate efficacy, olakizumab, tocilizumab, adalimumab, Bera, UPA all performed better than placebo. Shouldn't be surprising. Safety analysis was really kind of the shocker here, is their conclusion was that rituximab was the safest drug. Further subgroup analysis showed that JAK inhibitors and T-cell co-stimulation modulators were effective in D2R. And at the top of the heap, JAK inhibitors and IL-6 appeared to be the most efficacious. So the result of this, this study on the safety side concluded that rituximab was generally the safest drug, at least by the metrics that they had able to extract from these papers. Tocilizumab in full dose was highly effective, and JAK inhibitors and T-cell co-stimulators were found to be effective also in D2R RA. And JAK inhibitors and IL-6 inhibitors showed effectiveness, particularly in those that were refractory to conventional synthetic DMARDs. So that's a lot of crunching of a lot of data. And, you know, my off-the-cuff thoughts of this yeah, I think it showed the primacy of JAK inhibitors in this setting. I think that's much of our bias. I think that IL-6 plays a prominent role, but you know, the sniff test to me was the safety signal to rituximab. I just can't buy that.
Yeah, it doesn't. You wonder whether there's been some kind of channeling bias in the people that got into studies, and then the way the meta-analysis works is, at one level, it's kind of trying to normalize, and we've always got to give these kinds of studies the huge government health warning, which is that the trials were never designed to be compared one with the other. Now, these are, to be fair, these methodologies quite often come from the health economic literature. In that respect, they have maybe different tolerances. But I'm with you. I would be cautious of saying that rituximab was the safest of all the options based on this analysis alone. I guess the other thing that came across to me, Len, I don't know what you think about this, is I find the idea of difficult to treat RA quite hard to define. Now, I should just quickly qualify that because I'm a co-author and actually quite an enthusiast for the EULAR definition of difficult to treat. But I can tell you that was far from easily achieved, and I think still open to appropriate critique. Because, you know, you could be difficult to treat for so many different reasons. And it wasn't clear to me in this meta-analysis whether different difficult to treat populations were actually comparable. I don't know what you think about those elements.
You know, it's one of those settings that, you know, like so many other things that you know it when you see it. Yeah. But it's difficult to put on paper. And, you know, I don't really care that people fail because of toxicity. I can work my way around it. I want to know that they fail, and I want to know that the objective measurements of the disease are failing, and that these are not patients with nociplastic pain and other things. And it's just not, I don't think it's capable to sort out in a meta-analysis in a granular way.
So I guess the take home for our viewers is this adds to the body of knowledge, but is probably not the decisive factor in where we will eventually make our clinical decisions.
I think that's fair.
But a worthy addition nonetheless. Len, maybe you can tell us a bit about the Candiel paper as well, because it's a similarish kind of approach, which is why we brought them together in this podcast. So maybe back over to you just to take us through the second paper for this this event.
Yes, I found this paper to be of at least subjectively higher quality, and I think I got more out of this this manuscript. So, you know, this is JAK inhibitors versus TNF inhibitors in RA, and another meta-analytical comparison of efficacy and safety. So and there's a lot of data in here, and I'm just going to go with some high points. You know, in the growing availability of RA treatments, JAK and TNF inhibitors are just the stalwarts of our therapy. And previously, a systematic review and meta-analysis has failed to enhance clinical decision-making and guide the selection of optimal treatment strategies for patients. And again, because, you know, many of these studies are just not designed to be comparable. But the objective of this study was to compare the efficacy and safety of JAKs to TNF inhibitors in treating RA, and, you know, hopefully provide insights into the variability of patient responses, emphasizing the need for individualized, you know, treatment approaches, which is what we all want. So they, after they sorted out their entry criteria, had 16 RCTs two of the and in all meta-analysis, a linchpin of these type of studies is examining the heterogeneity of the trials, and there are statistical ways of doing this. And two had high risk of bias, 5 had some concerns, and 9 were at low risk of bias. So the outcomes assessed included both safety and efficacy. And I mean, there really were no big surprises here. And they looked at malignancies, excluding non-melanoma skin cancer, which is kind of ubiquitous, VTE in the terms of efficacy, CDI, and several patient-driven metrics, which I think are really important because they provide some insight into the results of this study. Looking at HAC and visual analog scales and globals. I'll come back to that in a bit. So the pooled analysis showed a significant increase in HAC disability score for the JAK inhibitor group compared to the TNF inhibitor group, and showing a differential effect. Pooled analysis showed an increase in the visual analog score for the JAK inhibitor group compared to the TNF inhibitor group. So now you've got two patient-driven metrics that you get a big vote for the JAK group. The pooled analysis of the CDI and patient global assessment really showed no significant difference between the JAK and the TNF inhibitor group. And I think that these two comparisons, we'll come back to that, are kind of telling. Both drug classes had, quote, comparable safety profiles for VTE and malignancies. And while they didn't really go into it, they do mention in their discussion that there's obviously a strong zoster signal with the JAK inhibitors, but it was not quantitatively appraised. And the high heterogeneity across the studies limited some of the interpretation. So in conclusion, JAK inhibitors demonstrated superior efficacy in improving functional status and reducing disease activity, particularly on the patient-driven metrics. Both drug classes were comparable for some of the really key worrisome toxicities such as VTE and malignancies. It was limited by high heterogeneity across these studies, reminding us of the difficulty with these type of trials. And I think the conclusion of further explanation into personalized treatment strategies that consider patient-specific factors, mind you, patient-specific factors, including genetic factors, disease severity, and beyond, could enhance the effectiveness and safety of our strategies for RA management.
Yeah, no, thanks, Len. Oral surveillance has a lot to answer for, doesn't it?
Yeah.
And, this is. I agree with you. I think this is an interesting meta-analysis. The data come out of RCTs, so we're reassured about the quality of the source data. I think we've already seen across quite a number of the phase 3 JAK development programs that there was always that feeling that they were just a little ahead of the TNF inhibitors, although sometimes statistical significance was achieved, other times it wasn't. I think certainly the international guidelines and recommendations have never separated the modes of action in terms of their likelihood of delivering a response. I'm not sure if studies like this will push international guidelines into that kind of differentiation, but it's helpful for us to have at the back of our mind that the patient, particularly patient-centric outcomes, look as if they're at least favorable in the JAK class. On the other hand, time and time again now, we're seeing these studies come out and saying, well, if we look at the data a different way from oral surveillance, we can't separate TNF inhibition from JAK inhibition for some of these more sinister events, VT, malignancy, and the like. What's your view on how this is going to bottom out? Because and just for the record, and for the purpose of this podcast, the FDA and the EMA and other global authorities have given us limitations on how we should use JAK inhibitors, and in no way are we in any sense trying to push back against those recommendations for prescribing. Need to be clear on that. But in the long term, Len, how do you think this is going to land? Will we ever get a resolution of whether there is indeed a safety risk that is greater than that we have with the TNF inhibitors for JAK inhibition?
Well, I'll come at this from two perspectives. On the safety side, I think that the concerns are real, but have been assuaged by a lot of real life data that have been reassuring. Yet at the same time, there is a vulnerable population that I think most of our colleagues and myself included, older people with cardiovascular risk profiles. I mean, this is just not the population we're eager to dive in with aggressive JAK therapy, and that's a significant swatch of this population. On the other hand, I think that there's growing data, and I believe this internally, that the JAK inhibitors have something else to offer. I mean, obviously, mechanistically, it's intriguing, but the fact that these patient derived outcome measures appear to be superior for JAKs versus other classes. I think that this is in line with much of the work we're seeing on the effects of JAK on pain. Some of this, really nice work done by Peter Taylor and others. I think there's really something there. The role of inflammatory cytokines and pain, both inflammatory, nociceptive, as well as neuropathic pain. I think it's a real deal. So
yeah, I agree with you. And I mean, many of us have mused on what the impact would be of a JAK inhibitor with higher blood-brain barrier penetration. Is there an effect of JAK inhibition in the central nervous system or in dorsal root ganglion, primary sensory neuron transmission? And I think that's a field to watch really carefully. But it's a great point to bring out, and it might be one of the reasons why the patient-reported outcomes are giving us this potential differentiation. There's a number of post-hoc analyses of the randomized phase 3 trials have come to a similar-ish conclusion.
Yes.
I guess just the final question I'd like to just pose, and I don't know if there's a right answer to this, just to manage expectation in the audience, but putting these two papers together, difficult to treat rheumatoid, the fact that we think JAK inhibition offers opportunities there is pretty clear. The problem is quite a lot of those difficult to treat patients are sometimes difficult to treat because they've got comorbidities or they are in that older age group. And so there's a collision of evidence here. On the one hand, we think we might be able to do better with that class of drugs. Maybe, I don't think that's proven, but there's some evidence that's beginning to gently push us in that direction. And yet that's the very group of patients in whom we're being told be very cautious. So I think there are going to be difficult trade-offs in the clinic. And I don't know what you think about it, but I'm constantly reminded that in oral surveillance, one of the key findings was that there was actually a lot of patients got into that trial whose primary cardiovascular risk hadn't been addressed with blood pressure lowering, statins. And in other words, we need to get our own house in order in managing multimorbidity, managing particularly cardiovascular comorbidities, and cancer risk prevention, dietary, thinking about smoking, etc. I don't know where you come in this discussion, Len, but for me, we must be observant of black box warnings, but we've got to treat the real people in the real world, and sometimes that's a value judgment that we have to make in full explanation to our patient. Or am I way off beam here, Len? I often am.
No, I think you're spot on, and I think that EMR wise and other algorithmic management techniques, we're constantly reminded in our system when we come to this diagnosis, and I think it should also be by by drug, has this patient been referred to preventive cardiology? And that's a big deal thing. And these guys are very aggressive and really doing things that are beyond what rheumatologists generally do. And I think that this is a good reminder of that.
Yeah. Len, I could chat to you all day about so many matters under the sun, but sadly our podcast needs to have at least some sense of time limitation. So I'm gonna pause our conversation for a little while. I'm gonna bring this podcast to conclusion. If you want to look at the publications that we've discussed, they've been uploaded onto the imedforum.com website. And when you go there, you will find that there are loads of other podcasts, lots of resources, papers. We do a lot of work in summarizing the papers in a quick to digest format. And also there's slide decks created from the data in the manuscripts, which you're free to download and use for educational purposes and disseminate beyond. The whole idea of the forum is that we create educational material and we all do our best to use that to further the benefits of our patients. Don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel to make sure you don't miss our podcast in the future. I have no idea how to subscribe to a podcast channel, but you're online listening, so you do. So please make sure you remember to do that. And as always, make sure to let us know what you think by leaving a review. So I'm going to finish by, first of all, thanking you, Len. It's always a joy to have that conversation with you. I always learn, and you know what? Today was absolutely no exception. So thank you. And thanks also to you, our audience, for tuning in, for your attention. I hope what we've discussed is useful to you in carrying on the most important mission of all, which is looking after the patients who trust us. Thanks ever so much. See you next time round.